So recent completion of the genomic work identified intrinsic subtypes in muscle-invasive bladder cancer, including our groups. Multiple group identified mainly basal and luminal muscle-invasive bladder subtypes, and those subtypes express the similar basal and luminal markers in breast cancer subtypes. So if you look at the basal cancers, and you can see the CK5 and 6 expression markers, and if you look at the luminal subtypes, you can see the CK20 marker expression. So except those marker expression, those intrinsic subtypes has prognostic features. So basal tumors are more aggressive with poor clinical outcomes. Meanwhile, luminal tumors has a better clinical outcomes. And in addition to this, and those intrinsic subtypes has a different chemotherapy response. So if you look at these luminal tumors, half of luminal tumor express the cancer-associated fibroblast. And we call this subtype as a P50-like. The reason we call this subtype as a P50-like is that if we look at the differential expressed gene in this subtype mainly expressed the P50-like signature. And we had two chemotherapy cohort, and then we subtyped those two cohorts, and then we look at the chemotherapy responses. So as you look at here, P50 like subtypes has an enrichment of the chemotherapy resistance. So after we figure out that P50 like subtype has a chemo resistance, we wanted to know about what's going to happen after chemotherapy treatment. So we collected 3 neoadjuvant chemotherapy cohorts from 3 different institutions, and all of them has a pre and post chemotherapy tumors, and then they have different treatment. So Fox Chase cohort, we got this one from the Betsy Primack, and then she did MBAC treatment. And then MD Anderson cohort, we have MBAC and Avastin treatment. And then Bern University cohort has a gemcitabine and cisplatin. So before we look at the chemotherapy-induced signature, we want to make sure the P53 subtypes can predict the chemotherapy resistance. So I only used the TUR tumors and then subtyped it. And then I found is that in all 3 different subtypes, in all 3 different cohort, we can see the enrichment of chemotherapy resistance in P53-like tumors. After we see this one, we want to see the relationship between pre and post chemotherapy treatment. So here I used the matched TUR and cystectomy tumors and subtype that. So this red color represents basal tumors, green color represents P50-like tumors, and blue color represents luminal tumors. So if you look at the TUR and cystectomy, in all 3 cohorts, you can see the increase of the P50-like subtypes. And bottom part is that expression of the P50-like signature, and those genes were enriched in cystectomy tumors. So after we see the P53 signature enrichment in chemotherapy-treated samples, we want to see what's going to happen except those P53-like signature. So we look the differential expressed gene between before and after chemotherapy treatment. So when I generated this heat map, this one is a ratio of the cystectomy versus TUR. So when you look at this one, the red color represents overexpression of those genes in cystectomy, and green color represents the downregulation of these genes in cystectomy. So as you see here, in all 3 cohorts has a cancer-associated fibroblast overexpression in cystectomy samples, and also EMT marker overexpression in cystectomy samples. So summary is that bladder cancer is heterogeneous. So this one has intrinsic subtypes. And one of the intrinsic subtype, P53-like subtype, has a resistance to the chemotherapy. And chemotherapy also induced the P53 release. In addition to that, and this one also induced cancer-associated fibroblast and EMT signature. Cancer-associated fibroblast has been known to control the chemo-resistant to prevent accumulation of chemotherapy reagent. And our data also suggested that chemotherapy recruited cancer-associated fibroblast. So we can use cancer-associated fibroblast as a therapeutic target in the clinic to increase the chemotherapeutic efficacy. So we are going to do further study using our in vivo preclinical models to identify the molecular pathways. Thank you.
So just curious in terms of sort of actionable issues. So when you're doing your biopsies and you're looking, how are you handling these patients? Do you have a novel protocol, novel agents? How do you manage these patients now that you know this information?
Okay, actually, so I'm kind of bioinformatician, so I got all the tissue from clinicians. So the Philadelphia cohort, I think Betsy Primek take care of it, and then MD Anderson cohort, we have Arlene Shipalaki, very like outstanding clinicians. I believe she did a very good job. And then Bowen cohort, I also got the data, so I'm not sure how the clinicians handle the patient.
Got it. Well, but it's quite interesting because it shows how much more we need to learn. So always more to learn.
Quick question. Nice presentation, very interesting data. I was struck last night by Dr. Bajorn's talk when he was mentioning the mutational burden of bladder cancer, and we think that this may correspond to the likelihood of response to immunotherapies. And I'm wondering, do you think that these some of these expression changes that you're seeing may be related to may be proportional to the mutation burden that are seen in bladder cancers, or is that not something you've been able to compare?
Okay, so this is RNA level, so we didn't look at the DNA mutations.
Yeah.
So, but what we saw is that, and I think like what's that, Jonathan Rosenberg like, published the ERCC2 has relations to the chemotherapy responses. So I only looked at the mRNA level, so which genes are correlated to the chemotherapy response. So what we saw is that, so if you look at this, when you go back this one, so in here, like a basal tumor says half of them has a chemotherapy response, half of them has a non-response, right? So when I look at the differential expressed gene between responders and non-responders in basal tumors, we can see the immune signature, so CTLA4, PD-L1, and those immune signatures were enriched in responders in basal tumors.
So we might have a DNA signature for immune response. We might have an RNA signature for immune response, but we don't know how they connect.
Right, this is the RNA signature.